Hello everyone. Am I audible to all?
Yes.
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Okay, thank you so much. A very warm welcome to all of you who have joined at this webinar today. I'm delighted to have you here for an educational session on a fantastic topic, genetic diagnosis and future prediction, brought to you by Heredity Biosciences. My name is Sushri Swagatika and I am the coordinator of this webinar. Heredity Biosciences is a well-known biotech company and research center based in Odisha as well as Guwahati. Before we proceed, I would like to introduce our esteemed speaker for today, Dr. Emili Banerjee. Dr. Banerjee is an expert in the field of genetic disease diagnosis and brings a wealth of knowledge and experience to this field. We are fortunate to have her share her insights with us. And I would like to take a moment to introduce our esteemed convener of today, Dr. Gopalkrishna Purohit. He is the CEO and co-founder of Heredity Biosciences, and he brings with him a wealth of knowledge and experience in the field of clinical genomics and infertility research. We are honored to have him leading us with this webinar. Before we proceed further, I would like to share some important information about the schedule and instructions for today's session. We kindly request all participants to stay until the end of the webinar. At the conclusion, we will provide a feedback link to you to share your thoughts and suggestions. Please note that only completed feedback forms will be considered for certificates. Your feedback is valuable to us and we appreciate your cooperation in this regard. Also, when it comes to asking questions or participating in the discussions, we kindly request that you maintain discipline and respect others' opinion. This will ensure a smooth and productive exchange of ideas. Now, without further delay, I am delighted to hand over the virtual stage to our director, Dr. Gopalkrishna Purohit. Once again, a warm welcome to all the participants. Let's make the most of this educational opportunity and learn together. Thank you, and over to you, Dr. Purohit. Please, sir.
Good afternoon, everyone.
Good afternoon, sir.
Hope my
Good
slide is
afternoon,
visible.
sir. Good afternoon, sir.
Good afternoon.
My slide is visible.
Yes, sir.
Yes, sir. Yes, sir.
Thank you.
Good afternoon, sir.
Thank you, Susri, for the wonderful introduction. Firstly, I would like to extend a warm welcome to all of you attending today's unique webinar. I am Dr. Gopalkrishna Purohit, CEO and co-founder of Heredity Biosciences. It is a pleasure to each and every one of you here with us. Today's webinar focus on the topics genetic diagnosis and future predictions. The subject holds immense importance as we explore the clinician and their healthy patients increasingly inquire about genetic testing as a tool of predicting diseases such as cancer, heart diseases, genetic diseases, and treatmental diseases. I want to express my deeper gratitude to Dr. Emili Banerjee, a distinguished certified genetics and genetic counselor, consultant, molecular biologist, genetic counselor at Life Science International Private Limited, for accepting our invitations to this guest speaker. Dr. Emili expertise and knowledge in field of food are truly commendable, and we are honored to have here share her insight with us. The webinar will provide an opportunity for all of us to expand to use of genetic testing has had a positive impact on patient care, bringing abundance of opportunity for diagnosis or prediction of future diagnosis. Dr. Emili, remarkable experience and contributions to the scientific community make her an invaluable resources for this webinar. We eagerly anticipate learning from her expertise and gaining insight into the current landscape of the predictions of disease risk in genomics and medicines. It's visible?
Yes, sir.
Okay. So now we move on this Heredity Biosciences. It is established in 2018 and reconstructed at Heredity Biosciences in 2021. It will become a prominent provider of research training services to hospitals, life sciences institute, pharmaceutical companies. It is a well-known, trusted among the doctors and research scientists. Heredity Biosciences back to a team experienced scientists and research professionals, and with a strong background of life sciences sector, healthcare sector, analytical and metabolic service industries, with a focus on delivering quality services and innovative products. The company is boosted to National Scientific Advisory Board and a highly skilled professional, including professors, doctors, and scientists in various fields of life sciences research, proteomic metabolism research, genetic diagnosis, and bioinformatics. Heredity Biosciences is dedicated highly quality and cost-effective solutions using diverse technology to support life sciences research, clinical sector, and industries, both in India and abroad. So we are delighted to announce the expansions of Heredity Biosciences with the inaugurated of our new branch in Guwahati. This is significant milestone comes along our existing location in Mayfair Lagoon Road, Bhubaneswar, and represent a momentous step forward to the company. With the opening of this Guwahati branch, we are delighted to strengthen our presence in the dynamic field of life sciences and healthcare research. Our new branch is equipped with a state-of-art laboratory facilities, enabling us to conduct advanced research and providing high-quality services and valuable clients. At Heredity Biosciences are committed to pursuing the boundaries of scientific innovations, remaining unwavering research. We strive to contribute to advancement of life sciences and healthcare research, empowering to the team dedicated researchers, professionals to explore the novel experimental methods and offer variable life sciences services and healthcare related aspects also. Our expansion of Guwahati not only enhances our capability, but also open to the door to collaboration of the esteemed institutions, healthcare professionals, and professionals to meet to the regions. We are excited about the opportunity. Thus, expansions begin to the positive impact we can make to the field of the life sciences sector and healthcare sectors. So at Heredity Biosciences, we are profound to offer a diverse portfolio of services in the field of life sciences and healthcare research. Our focus is on providing high quality services in two main areas like life sciences service and healthcare research services. In life sciences services, we are specialized in genomic, proteomics, and metabolomic services. Our advanced laboratory facility and expertise enabling us to offer comprehensive solutions in these areas. We are cater not only to the client from the Odisha, but also pan-India services, ensuring accessibility and convenience of our customers across the country. In healthcare research service, we contribute to the research-focused area that are crucial for advancing medical knowledge and improving patient outcomes. Our service is main domain included the clinical microbiology, infection genetics, cancer genetics, fertility genetics, and conventional PCR-based DNA studies. Through these services, we aim to contribute to the understanding, preventions, and treatment to the various diseases and conditions. We take pride to maintain to the high standard of quality and precision in our service. Our team and skilled professionals, including scientists, researchers, and technicians, utilize cutting-edge technology and the following strength protocols to ensure accurate and reliable results. At Heredity Biosciences, we understand the importance of research and the impact of the healthcare advancements that's why we are committed to provide comprehensive services that meet to the specific need of our clients and contribute to the broader scientific community. Now, we will move to highlight the training and research part. So, now the training and research part of Heredity Biosciences, we are the at Odisha, we are leading research training and research institute. We are proud to be offer comprehensive hands-on experimental research training to students and professionals. At Heredity Biosciences, providing various modules to cater a diverse interest of the particular field. These include clinical microbiology and genetics, clinical nanotechnology, microbial nanotechnology and genetics, food microbiology and genetics, and many others. Our aim to equip participate with the necessary knowledge and practical skills required for this chosen area of the expertise. Furthermore, we are excited to announce to the introduced specialized modules. These include clinical embryology, recombinant DNA technology with use of the qPCR and genetic diagnosis. These are designed to address to involving need to the advancement to the field of biosciences. So for more information to visit our websites also. Now we will move on the Heredity Biosciences infrastructure facilities. So Heredity Biosciences take a pride to provide expensive infrastructure facility to support the training and research path to the participants. We invite to visit our central facilities, witness the following features, both Bhubaneswar and Guwahati sites. World-class centralized air conditions laboratories. So our laboratory boosts to advancement equipment and technology, ensure to comfortable and conductive work environment for researchers and trainees. High connectivity Wi-Fi study environment, complete research learning facility. So, facility is equipped with the compressive storage in holistic and expert trainer and demonstrators. So our team demonstrate to the process to the expensive expertise to and experienced, provide to the invaluable guidance and maintenance to join up the study of this research. Well-equipped genomics and molecular biology, microbiology laboratory will complete hands-on individual experimental exposure. Practical learning, offering ample opportunity for participants to ensure in hands-on experiments. The independence, we are providing for the placement assistance. In first 4 to 5 to 6 months, we have achieved significant milestones at Heredity Biosciences. We take immense pride to the providing valuable opportunity to students and professionals in the field of biosciences. Here are some of the highlights of our recent accomplishments. So we have provided one-day training sessions over the 500 students in the Bhubaneswar and as well as the Guwahati sites. These sessions cover diverse subjects such as clinical microbiology, clinical genomics, hematology, and genetics. This is only available for the Saturday, and these sessions we will revise, providing the participants to side of the practical knowledge. That is a complete hands-on procedures. More than 300 to 400 students completed the short-term and long-term program, successfully completed the short-term and long-term intensive program. These programs offer complete hands-on experience, valuable expertise at the various research area, enabling a participant to develop the skills, career-based skills, and expand their understanding of the biosciences field. We are proud to be announced that Heredity Biosciences has successfully conducted the first time Odisha over the training for the Odisha benefits for the more than of the 500 students for the training session conducted to esteemed scientists and professionals. They are given for the certificate for the students. I extend our gratitude to the esteemed scientists and professors who graciously share their expertise and contribute to the success of the training program, and they are guiding to the mentorship. Undoubtedly, they are inspired and motivated to the student to pursue the scientific communities. These are some of the experimental activities is going on. Some of the research activities of this Heredity Biosciences research is going on. And over the past 3 to 4 months, we have tried to have actively engaged to the placement activities. We are able to share some of the highlight to the students' achievements. Several of our students have successfully completed to the interview and waiting for this joining. And we are delighted to announce to that they have been offered the position, eagerly waiting for the joining dates. We encourage to all the students to achievement to into the fruitful and reward to career ahead. At Heredity Biosciences, we prioritize to the career growth and success to our students. We strive to provide them to necessary support and resources to excel their chosen fields. Now, we are proud to collaborate to the remarkable achievement of Heredity Biosciences in the reclaim of research and collaborations. With over 50 publications, published research papers, our dedicated team has an unwavering commitment to pursuing to the boundary of scientific knowledge in the field of biosciences. Our strong collaboration with esteemed hospitals, research institutes, hospitals like SCD, KIMS, and some hospitals, and other hospitals also. We have instrumental facilities, meaningful connections between the world of academia and healthcare research. Through this partnership, we engage to the talented doctors, medical professionals, researchers to conduct experimental research, addressing the critical healthcare challenges and enhancing the patients' areas. So we are two patented already filed to this last 2 to 3 months, and one patent is already ongoing to the work. Now, the time for introduce our guest of speaker. Ladies and gentlemen, it is my honor to privilege to introduce our esteemed guest speaker for today's webinar, Dr. Emili Banerjee. Dr. Banerjee is a highly accomplished researcher in the field of human genetics with a wealth of experience in various roles. She is a certified geneticist and genetic counselor, consultant, and molecular biologist. Currently, she serves as a certified genetic counselor at MFIM Diagnosis and Ambrosia Neotia Healthcare Venture Limited. She is a genetic counselor at Nova IVF Fertility and Lifestyle International Private Limited. She is over 22 years in learning experience in human genetics. Dr. Banerjee holds a PhD where she focused on seronegative systems gene related to ADAS. Her expertise extends to Parkinson's disease, and she has spent 4 years in postdoctoral research in this area. She has been involved in the development of diagnosis tests and various genetic diseases, utilizing techniques such as cytogenetic analysis, real-time PCR, and NGS using ion torrents. Dr. Banerjee's academic journeys include a PhD in biotechnology from the University of Kolkata and a Master of Science in Zoology, Animal Biotechnology from Darjeeling Government College, where she was a silver medalist. Apart from her extensive work in research and genetics, Dr. Banerjee is passionate about genetic counseling. She has completed course in genetic counseling from IIM Avery and Welcome Genome Compass, and she holds a certificate in the genetic counseling from the Indian Medical Association. With a remarkable record of publishing research paper in international peer-reviewed journal, Dr. Banerjee contribute in the field of genetics. Her most recent publications in the Egyptian Journal of Medical Human Genetics, titled Genetic Counseling and Biomedical Bridge Between Molecular Diagnosis and Precision Treatment, showcase her dedications and advancement to the field. Please join me is given a warm welcome to Dr. Emili Banerjee as she has her invaluable insight with us today.
Thank you so much.
Yes, this is our team. Thank you, ma'am. This is now your turn.
Am I visible and audible? Hello?
Yes, ma'am.
Yes, ma'am.
Thanks for this warm welcome and 129 participants, 130 I can see. Such a huge audience, new minds, which is ready to be ignited. And thanks a lot to Dr. Purohit. I came to know a lot about Heredity Bioscience. They are doing a great work in Odisha as well as in Assam. And the students are getting a very good platform to develop themselves, to develop their knowledge. Thanks a lot for providing our country student with such a good and updated facility, and where you are arranging for different, they are getting different jobs and different placements, which is very essential nowadays. Only knowledge and then with particular application is necessary, which is there in Heredity Bioscience. Giving the knowledge, then leading them to their application, everything is there. So integrated approach, it's very nice. I'm highly impressed, in fact. Okay, good afternoon to all of you. I'll start my lecture with Shanti Bachanam, that is Sarve Bhavantu Sukhinaha, Sarve Santu Niramaya, Sarve Bhadrani Pashvantu, Mahakasri Dukhava Bhavet. That is, may everyone be happy, may everyone be healthy, may everyone see what is favorable, and may no one suffer. That is the motto. Okay, I'm starting my presentation. Just a minute. Is my screen visible? Is the presentation visible?
Yes,
Yes,
ma'am.
ma'am. Yes, ma'am.
Thank you.
Yes, ma'am.
Yes, ma'am.
If you like the cartoon, the first one, the concept of designer babies, very bad concept indeed. You may heard of the eugenics and all those things. Those days, genetics used to be a very bad thing to all the people. But this may come in a very different way. These days, we are thinking of that, not in just like that, the designer babies will be formed and we can choose that whether we want a doctor baby, whether we want a tech tycoon, and there is a 20% off also in that funny cartoonist. Parents actually don't want funny cartoonist. No, it is not that. These days, we are mainly doing the application of genetic diagnoses for curing and detecting different diseases, and to bring our next generation who will be free from the diseases which are being inherited in any particular family. So it is only for the betterment of us, not for any special choice. We are not try to bring our baby who will look like Aishwarya Rai with the blue eyes and everything. So here it is only about mainly focusing to eradicate different diseases which are having genetic basis. So genetic testing, we may think it in that way. Two types, diagnostic testing and predictive testing. Diagnostic testing, where there is already some symptoms are there, you are already having some symptoms, and we need to determine that what is the disease is. So to particularly diagnosis can be done using the genetic testing. And another is predictive testing, what is actually being evolved. The term of predictive testing by polygenic rescore and everything, that concept started long behind in 2007, but this is 2023 and still now we are evolving. Different companies, they are, I was just searching and was observing that different companies in our country also offering different testing for assessment of cardiac risk, for assessment of pharmacogenomics in which drug. I will respond better. So customized medicine and everything. But this needs to improve a lot. That I'll come and I'll explain why. So first, I'm focusing on diagnostic testing, that is genetic testing, which are helping us to find genetic diseases in many kinds of situations. Like a situation which is running in our family. Like in our family, a situation is running that is gallstone. My mother had, my grandmother had, my maternal aunties, they also had, I also had, my sister. So this is a situation that is running in our family. So we can test in the affected individual to diagnose to underline what is the underlying genetic components, and then what will be the procedure, that whether we need to go for gene sequencing or chromosomal microarray or MLPA testing or cytogenetic studies, that depends on the type of problem. If the type of problem, yeah, hello?
A simple
Hello?
structure which is meant to reinforce a simpler journey for our clients.
Is that okay? Hello? Hello? Oh, okay.
Yes.
Actually, I was hearing some sound and I got confused. Okay. So, whether we need to opt for a gene sequencing, we need to opt for a chromosomal microarray for the running situation in my family, that we need to decide by a genetic expert, that we may call him or her a geneticist, a genetic counselor, or a clinical geneticist. He or she will help us to determine that which particular test can detect the type of disease which is running in my family, and whether I am a carrier of that situation, how it can be transmitted, or we can stop the transmission to the next generation or not. First, we need to diagnose the one who is affected. We call them that the index patient, that who is affected in the family. We need to test in him or her, in the patient, and detect that which type of genetic change is underlying there behind the disease. And after identifying the cause, we can understand the relative risk. If we find that the change is an autosomal recessive kind of thing, then we can determine that in the next generation, what may be the risk, relative risk. You know that the relative risk will be 25%. If it is an X-linked one, then how it can be transmitted. If that autosomal dominant one. So first we need to detect within the individual who is affected in the family, what kind of genetic problem is underlying in him or her. Then only we can understand the relative risk, we can understand the mode of transmission, and can also determine whether any individual inherited the same variant or not. So there are several debates going on throughout the world, that when any individual in the family, they are having their information, like in my family, one of my son is affected with a kind of genetic problem. Whether I need to share and I got the diagnosis and everything, then genetic testing done also, and I got the information that in which gene, what kind of variation he or she is carrying and everything. Then whether I need to share the information with the rest of my family member or not. Here, if you ask me, as a genetic counselor, as a geneticist, I have faced several times problem that because people don't share the information, and it only increases the suffering of rest of the family members. So I will always request you that, okay, we are always admire your privacy and everything, but you should share, because sharing, here the sharing is caring. If you share the information, then they will be benefited from that information. So, and there is another kind where the individual is not yet have the symptoms. In that case, the late onset diseases like glaucoma, Parkinson's disease, Huntington disease, different kind of cancers, there individual, if we can identify the individual who are at pre-symptomatic phases, we can take action. Like that, here I can say about one project where I am involved. This is the multi-center project. It's going on with the collaboration of Salford University, UK, IGIB, CSIR, Government of India, IICB, CSIR. In collaboration, we are doing a project where we have identified in a remote village place, actually Dr. Chatterjee, he during his PhD work worked on glaucoma and its genetic causes. And during his PhD, he identified the genetic problem which was lying there it's an autosomal dominant kind of problem it was. And now we went to the village. We counseled. I, as a genetic counselor, went there. We counseled. It's a very big, large family comprising around 75 members total. Brothers, sisters, their families. It's a 3-generation family. And we collected their blood samples, even from the babies, few months old babies. We have collected their samples. And along with the eye specialists, we went there. Those who are at pre-symptomatic stages, we have identified them with the genetic variation, and we have arranged for medical camp for them. And we have arranged whenever the symptoms, repeated checking, the eye specialist suggested, recommended for repeated checking, every 6 months checking, and different medicines. And when at the point he will feel that the operation is necessary, he will intervene. So in that is a practical application of getting genetic knowledge, identify pre-symptomatic phase patient, and trying to stop the disease implementation. So in that way, genetic research is having a great application. So when we are having problem in genetic diagnosis, one of the thing is, that is the pleiotropy. That is one genetic variant. It is influencing numerous different phenotypic traits. It happens many times. This is succinate dehydrogenase gene. It is affecting so many phenotypes. And other two things are there: genetic heterogeneity and phenotypic pleiotropy. That is one phenotype which is being controlled by different genes, and one gene which is controlling different phenotypes. In all these cases, and another main thing is comorbidity, which we can very clearly observe in case of neurodevelopmental disorders, ADHD, ASD, Tourette syndrome, pervasive developmental disorder, depression, anxiety, all of them are sharing common genetic pathways. That's why the symptoms are overlapping with each other, and comorbidity is there. So in these cases, only by following the criteria providing in DSM-5, DSM-4, it is not enough. It is always good if we proceed through genetic diagnosis. Like in rare diseases, we came to know that a patient with rare diseases takes around 7 years to arrive at confirmed diagnosis. And these 7 years always comprises 4 to 5 misdiagnoses. So now another concept arises. I'm skipping few slides because these Another concept arises that this is genotype first approach. In different cases, I have just taken 2 cases from my personal experience. One case there, Master A, just an individual whom I named as Master A, born to a non-consanguineous marriage and referred to the physician for the impression of progressive myoclonic epilepsy. Is affected with subacute progressive encephalopathy and myoclonus with recurrent falls for the last 6 months. There was a big confusion regarding the diagnoses and everything. Then we opt for exome sequencing. And there we have what we have got. That is, the problem is there in the phosphatidylinositol glycan, that pathway, the problem was there. And glycosyl phosphatidylinositol biosynthesis defect identified. And the individual was homozygous for that variant, and it was autosomal recessive. Then what we have done the segregation analysis from the father and mother, and we got that both of them are carrier for that particular variation. So here the diagnosis was completely different what initially the clinician thought of. Another case is that B, who was referred for the impression of epilepsy, thinning of corpus callosum, difficulty in walking for 2 years, urinary disturbance, nystagmus, spastic paraparesis, and all these things. MRI of the brain reported diffuse cerebral atrophy. And then here, what we have got after the analysis, here we have got that the problem is homocystinuria, found to be compound heterozygous for MTHFR gene 2 variant. Compound heterozygous is one The individual inherited from the mother and another one inherited from the father. So two variations are in trans and they are having the effect on the MTHFR synthesis. Homocystinuria was the cause identified there. And another, this is a published study from Indian population only. This was published from CDFD. Actually, these lab I have learned my cytogenetic, all these things from Dr. Ashwin Dalal. They have published this thing, the genotyping first. Two siblings, a girl and a boy, they were presented with a history of developmental delay. That's a common one in all the neurodevelopmental diseases. Language regression, another common symptom which we found in case of autism, followed by non-verbal communication, having dysmorphic faces with hypertelorism, depressed nasal breach, low set ears, tongue thirst. Central nervous system examination revealed double hemiplegia, psychomotor retardation, and cognitive decline in both of them. So, and MRI suggestive of hypoxic changes in both the siblings. Then the diagnosis became very difficult. What may be the specific diagnosis? And without specific diagnosis, the treatment will also not be the proper one. So, how to determine what should be the diagnosis? So, then what they thought of do the genotype first. So they opt for NGS, and here they have got the homozygous variation in FUCA gene and the disease identified as fucosidosis 2. And then what they did, actually what usually we do, when the doctors, the clinicians, they refer the patient to us, and after getting the genotype done, we do reverse phenotyping. We try to match the genotype with the phenotype. Always with the, we try to match phenotype with the genotype. And here what they have identified the problem in the gene first, then went back to the disease phenotype. And the disease features when compared found to be perfectly associated with fucosidosis. So here the disease determination being done by the genetic sequencing only. This is the published data. That's why I kept that picture in the slide. Published data in Indian Journal of Medical Research in 2020 by Bhattacharjee et al. Mutations in the FUCA1 gene cause fucosidosis. This is a gene which provides instruction for making an enzyme, alpha-L fucosidase. And this enzyme plays a role in breakdown complexes of sugar molecules and attached to certain proteins, glycoproteins and fats. So this is responsible for cleaving of sugar molecule fucose toward the end of the breakdown process. There the problem was happening. So they identified the disease through genotyping, through next generation sequencing of the diseased individual. This is in case of the neurodevelopmental disorder, metabolic disorders, where there are lots of comorbidity, lots of phenotypes are overlapping with each other. In each of the cases, in my last 4 years career of genetic counseling, I've started doing genetic counseling in 2019. So from 2019 to 2023, I came across a lot of patients. And there, in most of the cases where I have seen that where the reason is very much overlapping, the phenotypes are like this, the problems with global developmental delay, speech regression, walking problem, all these things. Sometimes we are finding the reason in the neuro pathway, sometimes we are finding the reason in the metabolic pathway. And always, whenever we are trying to reach the solution through genetic analysis, the diagnostic yield is very high. Most of the cases, we came to know, we reached to the correct diagnosis through genetic sequencing only. And in case of epilepsy, in case of precision medicine and treatment in epilepsy, in different medical journals and papers published one, they have recommended that it should be included in the first tier of diagnosis of epilepsy, the genetic testing. Because when in epilepsy, the SCN1A Dravet syndrome, these genes are, variation in this gene is causing the symptoms, then the treatment will be sodium channel blockers. When the change we are finding in SCN8A, 2A, then sodium channel blockers may be effective in some cases. when we are getting changes in the potassium channel KCNQ2, there the carbamazepine and phenytoin are effective in these cases. And where the changes in SLC2A1 and encoding GLUT1, there the ketogenic diet is most effective. And I came across such cases where the changes in ALDH7A1, there the pyroxal 5' phosphate is the effective one. So here the treatment is completely depending on which system of the gene is being affected in the patient. So we need to, that should be the approach, that we should identify that which gene is involved, and then we decide what kind of treatment that patient will respond to. So this is after identifying the problem in the index patient, that who is affected one, then what we will do. In the next time when they will try to have their next generation, then what we can do? We can suggest, we can recommend them to proceed in two ways. First, they can proceed normally to bring their next generation. But always the question is, like me or like my first child who is affected, whether the second child will also be affected. Then what will the geneticist say? Usually what we recommend in that way, okay, you can bring your second child normally, but in that case, we should go through different testing, prenatal predictive testing are there, and prenatal diagnostic testing are there. When the prenatal diagnosis is a must, these are the situation: advanced maternal age, that is above 35, the mother's age, previous child with chromosomal abnormality, that may be cytogenetic abnormality, maybe deletion, duplication, family history of known genetic condition, recurrent miscarriage, maternal medical condition, congenital infection, and ART babies, that is assisted reproductive technique if they are opting for. In these cases, prenatal diagnosis is a must. And prenatal diagnosis, we can proceed in that way: non-invasive one and invasive one. Non-invasive one, these I will not elaborate. Only I will focus on this. You must have heard of this double marker, quadruple marker. These are predictive only. This can only predict that whether the common aneuploid is about trisomy 13, trisomy 18, trisomy 21, and XY chromosomes, aneuploidies. It can predict the risk, whether the risk will be high or the risk will be low. And NIPT, that is, you may have heard of, non-invasive prenatal testing. This is nowadays in great practice. Most of the physicians, they are practicing this. They are using this test for determining or screening. This is again a screening test. This is not a diagnostic one. This is the basic of NIPT. In NIPT, the fetal cells, cell-free fetal DNA, that from the placenta, it crosses the placenta and it comes to the maternal bloodstream. So in maternal blood, we can find the cell-free fetal DNA as well as cell-free DNA from the mother itself. And then we will tag, like we will tag the fetal DNA with blue and the maternal DNA with green, and then we alignment and counting. Like in chromosome 21, after alignment, what should we get? We will get 2 copies of chromosome 21 from the blue one and 2 copies from the green one. And then if we get 3 copies from the blue one and 2 copies in counting 2 copies from the green one, then we may say that the risk is high for trisomy 21 in the fetus. This is the technique, actually. This is a report where in NIPT, they are predicting that you can see that Z-score. They are calculating the Z-score. Z-score is being calculated in this way. Unique count of chromosome N divided by total unique count. By this chromosome, like in the below part of my slide, you can see that just above the graph, chromosome N Z-score for test sample, percentage of chromosome N, that is suppose chromosome 1 or chromosome 2 in the sample, minus mean of percentage of chromosome N in the reference, that is in a wild type individual where the chromosome count is exactly okay, divide by the standard deviation percentage of chromosome N in the reference. By that we calculate the Z score, and if the Z score is high, then we further investigation recommend, because and these further investigation are actually the invasive one. And the invasive one mainly are two types. One is chorionic villus sampling and another is amniocentesis. Any of you know about the, I am asking the students, I know the researcher and the doctors, they know that. Do you know about amniocentesis and CVS? Hello?
No, ma'am.
Okay. No problem. In case of chorionic villus sampling, actually you can see in the picture that a small part of the tissue guided by the ultrasonography, actually, it's mainly done in a transabdominal way. But from my few patients, I have heard that in different places, transvaginal way also, they are practicing these nowadays also. In past, they used to do that, but nowadays also in few places, the practice is going on. But in most of the places in East India, I have seen that they are doing in transabdominal procedure. Just a small amount of tissue from the placenta, they are taking out by guiding by the ultrasound. And from that, and it is being done in the after 10th week of gestation. Just after 10th week of gestation, this chorionic villus sampling can be done. And after that sampling, we can taste the sample that whether the second baby is also carrying the same kind of variation like the affected individual or not, definitely. And we can then guide the parents that whether this baby is going to develop any problem or the baby will be absolutely okay, or the baby just a carrier, not will develop any kind of diseases, that we can guide through the genetic counseling. And usually they take the decision themselves, the parents, they take the decision themselves if any abnormality is detected at all. And the amniocentesis we do after 14th week of gestation. Usually on 15th week or 16th week of gestation, we do that. Here guided by the ultrasonography, just a little amount of amniotic fluid being taken out. And in that amniotic fluid, actually, the fetus is shedding its skin cells. And from that amniotic fluid, we centrifuge the skin cell out, and from that, we isolate the DNA, and then we do the testing. Usually, if we ask for any, if we are expecting any kind of chromosomal aneuploidy, we can test through karyotyping, or if you are expecting any kind of small deletion, duplication, then we need to go for chromosomal microarray. And if we know, then in past generation, in the elder brother or elder sister, that it takes child, any particular mutation, any particular variation is existing, monogenic changes, then we can check for that through Sanger sequencing also. So, and it is a definitive one. So this is a diagnostic one. Based on this testing, we can take decision. This is not a screening one or predictive one. This is a diagnostic one. Based on that, we can take decision that, and always we need to correlate the genetic finding with the biochemical finding, imaging finding. If need to do the MRI, anything, we need to correlate the reports along with. Like we have found a change in the polycystic kidney disease, PKD1, we have found mutation and we are expecting to have the problem in the baby. Then in ultrasonography also, they will report that and need to correlate that. And after that, usually they take the decision along with the clinician, the pediatrician, they take the decision that whether to go for the termination, medical termination, or to continue with the pregnancy. Usually in our country, the medical termination is allowed up to 20 weeks of gestation. And if any problem, major problem detected, then after medical board, they need to decide, they need to recommend, then up to 24 weeks, the medical termination can be done legally. So this is about invasive testing, that is the NIPT. And after NIPT, we need to confirm through here, we have done through amniotic fluid testing. Here, trisomy 21 high risk was reported. And then from chromosomal microarray, again, then in chromosome 21, reported a pathogenic gain was reported. So now you need to explain to the parent that what are the problem that may develop. We cannot say that in Down syndrome individual, trisomy 21, you cannot say that to what amount the individual will be affected. I have seen many trisomy 21 individual, they are having cardiac problem. I have seen many trisomy 21 individual who are not that much active. They are in later time of their life. They are wheelchair dependent. And also I have seen Down syndrome individual who is studying in an engineering college, though after a lot of therapies, lot of toiling of her mother and everything, but she is improving a lot. She's doing regular jobs, going to regular school. So we explain those things that we cannot measure that this is 6. We cannot give any score to your child, but we can say these are the problem that may develop, but to what extent that we cannot say to them. Always we do the counseling in that way. And in counseling, it should be non-directive. So I shouldn't direct the patient, no, you need to keep the baby, because Down syndrome individual, they are getting Oscar nowadays. They are being a pilot nowadays. They are doing different jobs throughout the world. I cannot say that. So you need to keep the baby. Don't opt for termination. At the same time, I cannot say, no, Down syndrome baby, it may develop different cardiac problem. You need to check. Yeah, that I can say. You need to check through fetal echo and everything. You need to take care of that, I will say. But I cannot direct them to termination, or no, you don't have to termination. In that decision, I cannot direct them. I just need to say this may happen, that may happen, but no particular scoring I can give. That is the limitation actually. And presently, by non-invasive prenatal testing, that what we are doing through NIPT, that is just getting a blood sample from the mother only, through checking the cell-free fetal DNA, we can determine trisomy 21, trisomy 18, trisomy 13, gonosoma aneuploides, and few common microdeletion duplication. These are the microdeletion duplication. These are being offered by different companies in our country. D-George, that is very common in our Indian population. 1p36 deletion, 15q. You have heard of Prader-Willi, Angelman, Criducat, Wolfson. I have came across patient of Wolfson, Angelman, Prader-Willi, all these. So all these can be predicted. The risk can be predicted through NIPT. But if you want to diagnose it, then we need to offer them or tell them to opt for invasive testing, that is amniocentesis or chorionic or CVS. And by NIPT, we can predict the risk in remote areas of our country where the invasive testing, these are not available. I came across such patients, they are opting for NIPT, and then if the risk is predicted high, then they are coming to the places where the invasive testing is available. So cell-free fetal DNA, that allows us to non-invasively doing the prenatal testing, and no added risk of miscarriage is there, and this is highly sensitive. Particularly, we are telling that in case of Down syndrome detection, that is the trisomy 21 detection, it is around 99% perfect. And the false positive may come because of mainly placental mosaicism. That is the main reason for which sometimes, not sometimes, is very less. 1 or 2% cases I have found that false positive is there because of placental. False positive or false negative also I came across. It may happen because of placental mosaicism. So these are the limitation. And through NIPT, In our country, doctors are always asking through NIPT whether we can determine beta thalassemia, whether we can determine sickle cell anemia, but till now, NIPT cannot determine single nucleotide changes. So for gene level variation, detection is still now depending on the invasive fetal DNA sequencing, though in different research papers, I came across that they are doing it. In like in osteogenesis perfecta through NIPT, they have detected and published the study in a very esteemed journal, Nature. They have published that they are doing using NIPT single gene disorder. Maybe it's very near future that through NIPT, the single gene disorder also we can predict that whether it is going to develop in the child or not. That will be very easy and that will be very accessible for the patient population. So if we identified such changes in the index individual, in the family, this is, I explained for the normal pregnancy. And now this is in normal pregnancy, if we identified such problem, then the option is we need to opt for the termination of that pregnancy. But no cure is available. But that we can completely avoid that through pre-implantation genetic testing. There, by using self-gamete, what we need to do after preparation of the embryo, we can test the embryo. In different testings are available. I will not go into the detail. This is we are specifically calling pre-implantation. Nowadays, no PGS, no PGD or other thing. We just call it pre-implantation genetic testing. And we can check the embryos before implantation for aneuploidies, and we can check the embryo for single monogenic disorder like thalassemia, like CFTR gene problem, like sickle cell anemia, any monogenic problem. If we identify in the index child in the particular family, we can check that the embryos, which are carrying that particular variation in double dose, which are the embryo, which are carrying that particular change as a carrier and which are free from that variation. And after identifying the perfect euploid embryo, the implantation they are doing in the uterus of the mother, and in most of the cases, it is giving rise to a healthy child. So if we identify the genetic problem, it is not that there was time the patient used to say, if it is a genetic problem, what we will do after identification? Okay, we will treat the next child, but we will never have a healthy child again. But nowadays, the improvement in genetic research, we can get a healthy child. Not only that, you must have heard that in case of thalassemia, in the second child, if we match the HLA typing also, so from the cord blood of the second child, we can treat the first thalassemia affected child also. So PGT-M is there, pre-implantation genetic testing monogenic, PGT-A for aneuploidy checking, and PGT-SR. Because in case of recurrent pregnancy loss, where we see that most of the cases, in 30% around cases, we find that in the parents, there may be a balanced translocation is there. Balanced translocation is what? Where there is a no loss or gain of gene is present in the parents. And what we have seen in when the parent is having a balanced translocation, in most of the cases, it is giving rise to aneuploidy in the fetus. So in very early stage, the miscarriages are happening. So in my own patient, I have seen that the father was carrying a balanced translocation, and I have suggested for PGT-SR to them. And after doing PGT-SR, checking 4 embryos, they have only found 1 embryo to be perfectly euploid, and it was okay. And the implantation happened also, and the pregnancy is very successfully proceeding. We have checked through amniocentesis for whole exome sequencing, chromosomal microarray. Everything is okay, and I'm expecting that after 4 recurrent early miscarriages, they will have a healthy baby with help of the genetic testing only. So, and another thing, the screening test, you must have heard of newborn screening. In newborn screening, it's a burden in our population. 5 lakhs with congenital malformation, 10,000. I know it's very underrepresented. It's much more actually. Actual figure is much more. 10,000 with thalassemia major, and congenital hypothyroidism is also there. G6PD deficiency, phenylketonuria, 20,000 affected with Down syndrome, 4 lakhs with G6PD deficiency. These we can prevent if we opt for newborn screening. These are the diseases: phenylketonuria, congenital hypothyroidism. Usually when we come to know about those diseases, then already the problem implemented. After creating of the problem, after when the affected child is having the symptoms, then we go to the doctor. Already बहुत मतलब problem हो चुका होता है. लेकिन if we can identify that within the 24 hours, that is 48 hours to next 2 weeks, within next 2 weeks, if we can identify, then at particular time intervention can happen and they can have a normal life also. And these are the diseases: cystic fibrosis, galactosemia, lysosomal storage disorder, amino acid metabolic diseases, mainly the metabolic diseases, amino acid disorder, fatty acid disorder, organic acid disorder. I have seen last month, only 1st July, the date also I remember, 1st July, I went to Jharkhand in Rani Hospital. There, actually I do, every month I do a clinic there. There was one baby. We sent the newborn screening sample and it was identified as citrullinemia. And just after identifying, they have changed the medicine, they have changed the child, jo kha raha tha, everything they have changed. And now the baby is surviving and everything is responding to the treatment. लेकिन अगर हम लोग ये मतलब determine नहीं कर पाते, if we don't opt for that newborn screening, तो identify भी नहीं होता and maybe the baby वो मतलब हमारे साथ नहीं होते. So this is very effective, the newborn screening, and this is, I'm just completing with the diagnostic one and the screening one. The next part what I am going is that predictive one, predictive genetic testing. This kind of genetic testing usually help us to show how much of a chance we are having without those who are having without a family history of a disease may develop that disease. Predictive testing is available for health problem, some type of cancer, cardiovascular diseases, and some single gene disorders also. It's very comparatively to identify the single gene disorders are easy, but some disorders like the cardiovascular disease, like the diabetes, which we call as polygenic. Rather, these are multifactorial. And then what is polygenic? What is multifactorial? Polygenic is where different genetic systems are interacting with each other. And what is multifactorial? When this different genetic system along with the environment is creating the problem, is behind the disease, then we call the disease as multifactorial. In these cases, we need to determine that polygenic risk score. Here I got that in LinkedIn only. There, the slide was there, the 2 main and heart diseases. This James Fuller, he had a very good habits, but bad genes. Brought fitness revolution and jogging craze, but at 52, he died of heart attack while he was jogging only. And another, Sir Winston Churchill, ex-Prime Minister of UK, had bad habits, chain smoker, heavy alcoholic, but good genes. So he survived 7 to 8 strokes and lived up to 90 years. So knowing your genes matters, right? Not only having good habit will help you, you need to have good genes also. So this is the predicting future. Polygenic risk score is that thing. Predicting future disease is definitely more important than predicting ups and downs of the stock market or other things. So polygenic risk code analysis would be able to lead to the predictive diagnosis. Here what they do is that they actually determine a lot of single nucleotide variations in the particular group of a population. You need to know the ethnic basis, because the single nucleotide variation, one single nucleotide variation, just keep a single nucleotide variation A to G. In our population, in Indian population, maybe in the Northeast population, the A gene is having the major allele frequency and G is the minor allele frequency. Whereas just in Indian population, if I take a population isolate from the Andaman, there I will see it's just reverse. G is the major frequency and A is having the minor allele frequency. So here we need to know the ethnic background, and for different ethnic background, the control ones and the affected one should be correlated properly. The polygenic risk score analysis depends on comparative risk calculation of one's genetic makeup with those of normal group. And here I am just commenting on that normal group. That normal group should be ethnically matched. That is my point. As well as disease group genetic makeup database. Databases are there for different population, and we should consider the database from our population only for the normal or the control group. Though this approach needs more and more genome-wide association studies, including all populations and ethnicity, but studies are ongoing globally. They are trying to develop the databases very fast because of the next generation sequencing technique. And you know that long read sequences are also coming very soon in diagnostic practices. Then it will be more and more easy to sequence a whole human genome. Within few hours, they are doing that. So we expect that in near future, it will be possible to predict disease risk of individuals with much higher accuracy. Accuracy I'm talking about because we need to compare that SNP variation, we are the collection of SNPs. Like for cardiac disease, there are a lot of genes, lot of variations which are involved to increase for increasing the risk of cardiac diseases. So we need to compare all those SNP in the affected individual with the control, and that control should be ethnically matched, age matched, gender matched. These things are very important in human genetics. So this is actually the ideal, this is PRS's polygenic risk score. First, we need to identify the disease-associated variation within a particular population. Yellow one is first. Next, coming to the red one, the pink one rather. Then after identify the disease-associated variation, we will predict that whether the drug reaction, whether with the particular variation, any adverse drug reaction is there. Then we need to optimize the efficacy, that in which dose the drug is creating adverse effect. So individual dose requirement or response. And the last is the green one, predicting effects on downstream modulation. Okay, this is acting on the such and such gene. Then downstream of that, whether it is creating any problem downstream of that genetic pathway. So if where the everything is matches, that there we are developing an ideal polygenic risk score, and then we can develop a personalized medicine that is the base of our pharmacogenomics research. That is the precision medicine, a medicine which will be for, okay, I am having influenza and such of my neighborhood, he is also having. But which drug should be given to him, to me, and what should be the dose? That in that level, to that level, we are trying to reach, and I think we will reach very soon. And last, most predictive test that I told you, that if a condition will develop or not, when it might develop, and how sick you will get, that we cannot tell. Just we can tell that this is the risk, that much is the polygenic risk score, that much you may develop that one. This is the risk is high, or the like that, the threshold for clinical action, whether it is below the threshold, you need to take the clinical action or not, that much we can tell, but not in great detail till now. And I'm ending my lecture with a past story. Many of you may have heard about that. This is a very heart-touching story and which get resolved only by genetic testing. So by studying the human genetics, you can help to treat, you can help to bring their next generation, healthy next generation. We can help to diagnose a particular disease properly. You can help an individual to take decision. You can be a crime detective also, right? Here what happened, that Kathleen Forbick, she found guilty for killing her babies, 4 child. The diet in a very short time span, and because there was no direct evidence or anything, and the mother was suffering from after pregnancy depression. So on few circumstances, they found her guilty, and she was having, I think, above 20 years she was in jail. And after that, one of her friend, she was a scientist, a geneticist, and what she did, she took out that, because it was stored, the DNA sample of her babies, and she took out that, and she found that a novel functional calmodulin variant which can cause idiopathic ventricular fibrillation, that is long QT syndrome, and maybe a fatal arrhythmic attack may happen triggered by their intercurrent infection. So they may have a natural death. The culprit was a mutation of the DNA, and it found that the pathology of their child also matching with that calmodulopathy. So the reason for their sudden death was just cardiac arrest, not any activity by their mother. And then they checked that with the mutation was inherited from father and mother, everything matched. And then the convicted mother not found guilty, and then get freed from the jail. So here, for the case solving, like the detective in our Bengal, we call Feluda, Bhumkesh Bokshi, Sherlock Holmes, like that. You can, being a geneticist, you can play the role of that. So genetics is everywhere, in disease solution to crime solving, everywhere. Genetics is playing his important role. In future, it may happen that at the time of marriage, they will say that, do you, Ashley, take Nesbitt and his genome to be your husband? So this is the near future, maybe. Thank you. Thanks a lot for your patience.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you. Thank you for listening.
Thank you, ma'am.
Have you heard these things? And any one of you found interest to be genetic counselor in future?
Yes, ma'am.
Yes, ma'am.
Sure, ma'am.
Sir, what you are telling? Dr. Purohit, I am asking Dr. Purohit.
Yes, ma'am. Ma'am, again, pardon.
Yeah, actually, this is, I just came due to some circumstances in that. I have done my PhD, then I have done my postdoc, and I was working as a research scientist in a lab. Then suddenly, due to my family reason, I had to resign from that job because of my son, actually. I had to resign from that job. And then at that time, I was practicing genetic counseling. In that lab, actually, they were telling, after when we will release the reports, we will make the patient understand that what they will do. Then I came across all the genetic counseling courses and other things that are available in our country. I went to Hyderabad. In Hyderabad CDFD, I did the training, and then there in Kamineni Hospital, I came to know about BGCI. I appeared in their exam and passed it. So in that way, I came into that somehow in genetic counseling. And because of patient response only, my family told me that all of your patients are very happy, and whenever you are coming out from your chamber, I see that your face is glowing. you should stay in this job. Then now I'm a full-time genetic counselor. And this is a very good career option for human genetic student. Not only being a genetic counselor, genome analyst, this is again a very good career option. Being an embryologist, being a genome analyst, being a genetic counselor, all these are very good career options for the students of biotechnology and human genetics.
Yeah, ma'am. Yes, ma'am. Ma'am, one question my side.
Yes, sir. Please.
What is happening if the patient is get a positive NIPT results?
Yes, sir.
So,
So then we should recommend them for invasive testing, because without invasive testing, this is the diagnostic one, we cannot take any decision. We cannot tell them this is the perfect one. Yes, they are telling in NIPT that trisomy 21 risk is high. Okay, it will happen. No, we need to reconfirmation through amniocentesis, and that just like I showed, by karyotyping, by FISH, by chromosomal microarray, by any of the, by QF-PCR also. If we confirm, then we can guide the patient or recommend the patient. That is the thing that is present in your fetus. Now you take the decision.
but if it is a low risk patients,
Then it's okay, sir. If they are predicting that low risk is there, then just proceed with the normal ultrasonography screening. At 28th week, the fetal screening, the growth scan, everything is okay. No need to take any actions. And sometimes we also tell them that after USG scan, if any problem determined, like the brain development, these things are identified just after 18 weeks, 18 to 20 weeks. So these things are not, in NIPT, only aneuploidies are there. Partial duplication, partial deletions, this will not be identified. So again, we need to depend on the ultrasonography.
Okay.
In ultrasonography, if they find anything, then we need to again go for the invasive one. Ultimately, for all things, for decision taking, we need to come to the invasive one.
doctors. Yes.
Lot of things they are writing here.
So many, ma'am.
You can send me, you can take my WhatsApp number from sir.
All this we will give to the ma'am's WhatsApp number. Any questions to that?
Yes,
everyone
any
share
queries.
these things.
Any queries, you just need to say that you are from that Heredity Bioscience, and I will answer. Obviously, I will answer. Actually, not only I am a genetic counselor, I forgot to tell you, I am a guest faculty of University of Calcutta Genetics Department. For a long time, I am attached to Genetics Department, Calcutta University. From 2017, I am continuously there in Human Genetics Department. Before that, at my time of my postdoc also, I teach there. I used to teach there. So you can ask me anything. No problem.
Now the audience side, any questions?
If now anything is not coming in your mind, I'm telling you, you just, I have seen the students are feeling shy, or I will ask this question, what people will think about me. Don't worry, you just WhatsApp me.
Any questions for studium sites? I think everyone should be understood this topic, ma'am. But this is an excellent topic, ma'am. This is my favorite topic also. So, you are really amazing, ma'am. It's a nice talk today, and a lot of doctors, and I'm associated for that. And I, as a embryologist, as well as for this training for the embryology course, and my PhD also going for this genetics part, and I am counseling for some of the patients also sometimes before, and fertility patients. So it's
Then
a
I'll
very
be there next Tuesday. I'll be there in Bhubaneswar.
Yes, ma'am. So, any questions from audience sides? Ma'am, I will share to the WhatsApp number to everyone. And
Yes, please, sir. Please, sir. No problem.
Even for that. Any questions?
I'll be there in Tuesday. I'll be there in Bhubaneswar for just a seminar only, to give a talk only. So I frequently visit. Last time I went to Cuttack for a conference on World Kidney Day. I went there. So I visit Odisha very frequently.
Okay, when you will coming to this Bhubaneswar, ma'am, just to let us know so that we will be reach you, and once you will visit in our lab, ma'am.
Yes, sir. I will love to do that. I have seen the videos that you have. It's very good, very well developed, very well structured. It's very good, very updated. Just at the cutting edge, doing the biological sciences. Very nice, sir. Thanks a lot.
Ma'am, we are trying to get the knowledge to the students, empowering to the students, professionals, because they don't know that how they move to the career to the right field. So that's why we are taking to the initiative. So you people are really amazing to accept our invitations. So that's why we empowering to the audience, means life sciences professionals. So the students really waiting for this today's presentations, and these presentations you are delivering. It's really amazing. And finally, I will give in for the thanks to ma'am on behalf of this Heredity Biosciences and all participants to today's webinar. I extend my heartfelt gratitude to our esteemed guest speaker, Emili ma'am. It has been an absolute honor and a privilege to with us today, and sharing to the extensive knowledge and expertise in the field of human genetics. It's really amazing, and your presentation of genetic and diagnosis of future predictions is really amazing, ma'am. It has been nothing sort of a enlightening to the audience, inspiring. It's enlightening to the advancement of the implementing of the genetic diagnosis and healthcare that you have to listing in part to us, and our dedications, research, and passions of this genetic counseling means truly it's a part of distinguishing part to the this emerging field. And we are really grateful to you in valuable time and effort to the aspiring to this today's webinar. You are engaging to the talk, and all these participants 130 to 133, everyone to be listening carefully, and no one to left to this webinar, and they carefully listens to the genetic diagnosis also. This is this grateful and valuable times you are sharing to us, and effort to the preparing to the today's webinar, and then grand success for that. And you are engaging talk to capability to the audience without leaving to them deeper understand to the subject matter to the really to the genetic diagnosis. So we are appreciated your willingness to address inquiries. Any doubt to this audience, and you raised the questions, I will share to the ma'am's WhatsApp number, and whatever you have a questions, you should be shared to personally to the ma'am.
For your future, any guidance, anything also, you can contact me in LinkedIn. I'm there. I'm very active in LinkedIn and WhatsApp, actually. So you can ask me. You just tell that you are a student of Heredity Biosciences. Before also, was University of Delhi, DTU, with them also have done one webinar. They have asked me for giving a talk on premarital and preconceptional screening, genetic screening on that. So they also till now they're contacting me for different career options, different problems. You can ask me. Really, I'm very approachable. Don't worry.
Okay, ma'am. Once again, thank you for listening to your presence and sharing your valuable thought to the genetic diagnosis. And your contribution in this webinar has been invaluable. And we hope to have a pleasure to be collaborating with within the future. Any of this research part, any of this diagnosis part, whatever the research part, we will try to collaborate you in this future. And we also extend our gratitude and on behalf of all these participants, this active engagement and enthusiasm throughout these sessions, man. Your presence has made in the awareness is resounding and grateful success, man. Grand success. Thank you. Thank you for your presence. Thank you all for joining us today, man. And look forward to continue to the interactions and fruitful collaboration to the further future in the field of either life sciences or as well as for the genetic diagnosis. Thank you.